Good afternoon, everybody. My name's John Sapp. I'm one of the heart rhythm specialists at the QE2, and I'm delighted to have the chance to join you today. It looks like a great agenda. This is pre-recorded, but I'm virtually here live with you, and we'll be able to have a discussion after this portion. I was asked to talk about anticoagulation, bleeding risk for atrial fibrillation in sort of special circumstances and how to manage that. Here are my disclosures. Let's start with a case. This is a real case that I saw on call a week and a half ago. A 66-year-old man came in. He had had a non-ST elevation MI a few weeks ago, which was treated with a drug-eluting stent to his culprit LAD. Here you can see he's got a fairly ugly long segment just after the first diagonal, and he had a great result with a stent. This is his past medical history. He had a single kidney, having donated one previously. He's an ex-smoker. He has a history of high blood pressure, but he's not diabetic. And he came in early enough with his non-ST elevation MI that his ejection fraction was preserved. So after his successful PCI, he was discharged home on ticagrelor and aspirin, as well as the usual medications. And he comes in now with palpitations and this electrocardiogram. You can see that this shows atrial fibrillation with a relatively controlled ventricular rate. He's got a left anterior hemiblock, no convincing Q waves, pretty decent R wave progression across the precordium, some non-specific T flattening in multiple leads. And the atrium is fibrillating. So now we have a person on aspirin, ticagrelor, and he has an indication for anticoagulation. So what do we do? Should he be on triple therapy? Or how do we manage this for him? So let's talk a little bit about the risk, the relative merits of each of those. As I'm sure everyone here knows, atrial fibrillation raises the risk of stroke by approximately 400%. And as one of the most effective treatments in all of medicine, anticoagulation reduces that risk nearly to the risk it would be without atrial fibrillation. So by 50, 60% or more, depending on the trial. At the same time, he has an indication for antiplatelet agents to prevent stent thrombosis. Antiplatelet agents are effective against arterial thrombus formation, but not very effective against venous or left atrial thrombus formation. Anticoagulants can be effective against both. By anticoagulants, I mean warfarin and the non-vitamin K dependent anticoagulants, which we'll call the DOACs. And they are quite effective against left atrial thrombus formation. So these are the Canadian guidelines for anticoagulation. They were published in 2020. It's really an excellent guideline document. So if you have not had an opportunity to go through it, I highly recommend it. I've actually been through it a number of times and keep going back for reference. It's quite well written and very thoughtful. So this is the so-called Canadian CHAD 65 approach to anticoagulation. So for people with paroxysmal or persistent atrial fibrillation, paroxysmal or persistent atrial flutter, the recommendations are to treat them according to this algorithm. If the age is over 65, more than or equal to 65, or there's a history of prior cerebral thromboembolism, TIA, or stroke, a history of hypertension, a history of heart failure or reduced ejection fraction, or a history of diabetes, then unless there's an excessive bleeding risk, anticoagulation is preferred. And these guidelines went on to specifically recommend DOACs over warfarin because of the greater ease of use, similar or perhaps better efficacy, and similar or lower risk of bleeding, especially cerebral hemorrhage. As you may know, vascular disease is part of the CHADS VASC score and is also a clinical risk factor for stroke in atrial fibrillation. But it may not carry as much risk. And so the usual recommendation is if they don't have any of the other traditional CHADS-2 scores or age over 65, then they can be treated with an antiplatelet agent if they have vascular disease. And the drugs that are appropriate for that would be aspirin or one of the newer drugs, clopidogrel or ticagrelor or prasugrel, for example. Or there is some trial evidence for the use of low-dose rivaroxaban, so-called vascular dosing of 2.5 milligrams twice a day. And if they don't have arterial disease or vascular disease, then an antithrombotic is not necessarily recommended. What about the risk of bleeding? Well, of course, nothing in medicine comes for free, and the risk of major bleeding is doubled in the presence of anticoagulation. So it may raise the baseline bleeding risk from 0.5% to 1%, or if they have a higher clinical baseline risk characteristics for bleeding, even higher. This is the HAS-BLED score. It's one of a few clinical scoring schemes that have been put together to try to estimate the risk of bleeding. And maybe not so helpfully, many of the clinical factors which raise the risk of thromboembolism in atrial fib and would recommend anticoagulation also are associated with a higher risk of bleeding, and so might argue against it, I suppose. So those are things like uncontrolled hypertension, renal failure, liver failure for multiple reasons, or at least liver dysfunction. So that, of course, can lead to gastric disease, esophageal varices, a coagulopathy, and even a prothrombotic state. History of stroke, use of warfarin with labile INR, so in the therapeutic range, less than 60% of the time, has been associated with high risk of bleeding. Age over 65, use of antiplatelets or anti-inflammatory drugs, and alcohol use. So as you can see, many of the things that make up the CHADS-VASc score also make up the HAS-BLED score. So how do we deal with this? When atrial fib and coronary disease coexist, and we end up thinking about, do we put them on two antiplatelet agents as well as an anticoagulant? So let's go through this a little bit. These two diseases commonly coexist, and while atrial fib probably doesn't cause atherosclerotic disease and its sequelae may lead to the raised filling pressures that can stretch the atrium, lead to atrial remodeling, and predispose to atrial fibrillation. Antiplatelet agents are known to reduce the risk of acute coronary syndrome and stent thrombosis, but of course, as we just talked about, combining antithrombotic therapies raises the risk of bleeding. So what can we do to lower the risk of bleeding? There are some motherhood and apple pie measures that we can undertake. We should try to avoid combining prasugrel or ticagrelor with the DOACs. They're more effective and raise the risk of bleeding. Clopidogrel has been shown to be effective in clinical trials and is the preferred agent for combination therapy. We can consider using a prophylactic proton pump inhibitor to reduce the risk of gastritis and GI bleeding. If using warfarin, we can target a lower range INR, so 2 to 2.5 instead of 2 to 3, trying to tightly control the INR. We can try to avoid the use of nonsteroidal anti-inflammatories, which of course do have some antiplatelet effect, but more importantly, can cause gastritis and raise the risk of GI bleeding. We should make sure that the blood pressure is strictly controlled. And in general, DOACs are preferred to warfarin for their more predictable pharmacology and lower bleeding risk. Let's think about stable coronary disease for a moment. So this is a patient who's not presenting with acute coronary syndrome, but does have coronary disease, and they have atrial fibrillation. So if vascular disease is their only risk factor for stroke with their atrial fibrillation, so they are aged under 65, no diabetes, no high blood pressure, no prior stroke, no heart failure or ventricular dysfunction, so vascular disease is their only stroke risk factor, then aspirin monotherapy would be the usual choice. It's not wrong to add rivaroxaban. The COMPASS trial published in 2017 compared the use of aspirin to rivaroxaban, low dose, 2.5 milligrams twice a day, or rivaroxaban plus aspirin. And what they saw was that adding rivaroxaban to aspirin was slightly more effective, but very slightly. And rivaroxaban alone was as effective or slightly more effective than aspirin alone. But with each of those incremental benefits, you also pay a small bleeding risk price. So that trial was in patients who did not have atrial fibrillation. That was just for patients with coronary disease. But that knowledge has been translated over to think about patients who maybe have a lower stroke risk and need anticoagulation. Let's think now about patients who have stable coronary disease. That means they're not presenting with an acute coronary syndrome, but they have coronary disease and they have atrial fibrillation. And let's say that their CHAD 65 score is 1 or more. So they have one of those risk factors. Then the usual approach would be to use a DOAC, or you could use warfarin, which is perhaps not preferred, but reasonable as a choice. And you don't need to add on aspirin or an antiplatelet agent. So the anticoagulant can replace the aspirin. You don't have to combine them. And this advice is based on some pretty old trials now from nearly 20 years ago, the Walrus trial, which looked at warfarin with aspirin versus warfarin versus aspirin alone. And similarly, the Aspect 2 trial in the Lancet from the same era, showing that warfarin was an acceptable alternative to aspirin, but that the combination of the two raised the bleeding risk without a lot of incremental clinical benefit. So anticoagulant alone, and don't need to have an antiplatelet agent. Okay, let's now consider patients who have an unstable coronary disease, so a non-STEMI or an acute coronary syndrome, and now you've got to make decisions about what to do. And they also have atrial fibrillation either before or during the acute coronary syndrome. If their CHAD 65 score is 0, then you don't need to add on a anticoagulant. You can use dual antiplatelet therapy as we normally would. So if they get a stent, they're going to have dual therapy for a year and then aspirin indefinitely. If they have an acute coronary syndrome and don't have a PCI, then dual antiplatelet therapy for 6 months and then aspirin lifelong. But if they do have a higher CHAD 65 score, then they are at higher risk not only for stroke or thromboembolism, but also for acute ischemia, coronary disease, whether it's stent thrombosis or worsening of a prior unstable plaque. So in that situation, triple therapy is recommended. But depending on how sick they are and what you perceive their thromboembolic risk to be, you may be able to stop the aspirin after a PCI is performed. So once again, DOACs are preferred over warfarin, more predictable, maybe less bleeding risk, less drug interactions and food interactions. Because we're going to be combining therapy, we're going to use clopidogrel rather than ticagrelor or prasugrel. And if the CHAD 65 score is just 1, so they're at the relatively low end of the stroke risk, maybe that's the kind of patient where you could consider just dual antiplatelet therapy and not use a DOAC. So aspirin plus ticagrelor and hold off on the anticoagulation. So let's say they just have hypertension and nothing else. So here's the same information in graphic form. So a patient comes in with a CHAD 65 score of 1 or more, an acute coronary syndrome. If they don't have a PCI, or that's a, let's call it low risk PCI, then they can be treated with clopidogrel plus an anticoagulant, whether that's warfarin, apixaban, dabigatran, edoxaban, or rivaroxaban. But if they have any of these high risk features that we've listed over here on the right, like diabetes, they're a smoker, renal dysfunction, multivessel disease, long stents or multiple stents, complex lesions identified at the time of PCI, whether they have a prior stent or a prior stent thrombosis or a chronic total occlusion, any of those that might raise their coronary risk, or it's an acute coronary syndrome and they have a PCI, then we're going to start with triple therapy. So that means they're going to get aspirin and clopidogrel and a DOAC or warfarin. And The guidelines would suggest that you can stop that up as early as 1 day after the PCI, but it should be started ahead of time, or perhaps up to a month of this triple therapy. And then you drop down to clopidogrel plus um, the anticoagulant for up to a year. And then you could dial it back to just the DOAC. So let's put this all together in one sort of progressive image. So at the far end of risk on the far left is somebody with stable coronary disease and a low CHA2DS2-VASc score, low CHA2DS2-65 score, treatment with aspirin alone. You could consider adding rivaroxaban low dose if you wanted. Stepping it up one risk layer would be stable coronary disease, and they have an elevated thromboembolic risk. Then instead of aspirin, we're going to use the DOAC or an oral anticoagulant. In some special circumstances where they're perceived to be at especially high risk, one might consider combination therapy. Okay, now let's step it up one more layer to an acute coronary syndrome that's not treated invasively, or a low risk PCI. That means they don't have those risk factors that I've listed in the top right corner. Again, clopidogrel plus the oral anticoagulant. And then in our highest risk category, that is an acute coronary syndrome treated with a stent, or an elective PCI but high risk features as listed, then we're going to use triple therapy for as long as a month, and then dial it back to dual therapy, and then dial it back after 12 months to oral anticoagulant alone. So there are patient factors that raise and lower the risk. That is age over 65, low body weight, high blood pressure. Those are things that increase the risk of bleeding. And there are patient factors that increase the risk of thromboembolic events as well. I don't think we need to go through all the details of the slide, but these will be familiar to many of us just from our usual clinical experience. So let's go back to our patient. He just had a stent in his LAD. He had high blood pressure. His EF was preserved. So he went home on ticagrelor and aspirin. He has two of our risk factors. His age is 66 and he's hypertensive. He's someone that, and he's come in with atrial fibrillation. So he kind of fits in this third category, except that he's now a month or so after his stent. His stroke risk factors are his vascular disease, his age being 66, and hypertension. So we kind of figured he'd already been through his highest risk post-stent period, and we switched him to a DOAC with clopidogrel. A couple of more points. What if the patient's having an operation? Do you stop the drug? When do you restart it? And this is going to come down to your clinical judgment again. So some procedures have minimal bleeding risk. Some have moderate bleeding risk, of course, and some have high risk. The high risk ones are neurosurgery, really where bleeding at a non-compressible site is likely to cause major trouble. So this is really complicated starting and stop time recommendations, which I've only put to show you that you really just need to use your general clinical judgment. Leave a little bit more time to stop dabigatran than the other DOACs prior to an invasive procedure. And of warfarin, of course, you need to stop like 5 days ahead to let it wear off, unless you're going to reverse it. But of course, if you reverse it, it's hard to restart it. And after an operation, you're generally going to resume when the interventioning physician thinks it's safe to do so. And what if bleeding occurs? If it's major bleeding, that means bleeding from a critical site like neurologic bleeding, pericardial bleeding, airway bleeding, or GI, retroperitoneal, or intramuscular, or joint bleed, which can cause permanent injury. Then you're going to stop the anticoagulant, do whatever you need to do, whether it's surgical or interventional, to stop or control the bleeding, put pressure on it, or scope them and cauterize the bleeding artery in the stomach. And if it's severe, you're going to use a reversal agent. That's really the main time that we're going to be using a reversal agent, if it's critical site bleeding and it's life-threatening and you can't afford to wait. Non-critical site bleeding, usually they'll try to control it and stop the anticoagulant. And for less major bleeding, of course, stop the anticoagulant. Of course, volume resuscitation and usual medical care are going to be important. And just another note that IV vitamin K given over half an hour, 15 minutes will rapidly reverse the INR within 4 to 6 hours. So that is actually reasonably effective. I don't want to spend too much time on these because often if I'm having to use these, we're phoning the pharmacy and asking for what we need to give, or it's being given in the emergency room. So I do not often get called to use these drugs. I can think of maybe twice. But to rapidly reverse warfarin in an emergency, like a pericardial bleed, then the activated prothrombin complex concentrate like octaplex can be used, and there are dose adjustments that I don't keep in my head. For dabigatran, again, you can use Praxbind or the prothrombin complex concentrate. If they've recently taken their drug, like in the last few hours, you can try to also absorb what's in their stomach with activated charcoal. And the same goes for the non-dabigatran anticoagulants, for which we don't have andexanet alpha, the reversal agent. Just a final note that the anticoagulant half-lives are here. Dabigatran is more renal dependent, longer half-life for patients with very impaired renal dysfunction. But most of these drugs have half-lives in the 6 to 17-hour range, and so you can usually just stop the drug and let it wear off. When you're deciding to restart the drug, use your clinical judgment, of course. Is the bleeding source controlled? How high is their risk of thromboembolism? How urgently do we need to anticoagulate them? And what's the risk of rebleeding? So let's come back to our patient. And now we're going to pretend this didn't really happen, but we're going to pretend that he comes in with melena and a hemoglobin drop. So here's his history. He's dual anti-thrombotic therapy with a DOAC and antiplatelet agent, atrial fibrillation, and he's having an upper GI bleed. So this is critical site bleeding. He's had a big hemoglobin drop. He's in trouble. We're going to volume resuscitate him, and he needs an urgent scope. We stopped the Plavix and the DOAC. And you're going to decide whether to give the activated protein complex, depending on whether you think he's actively, aggressively, rapidly bleeding. If so, give it. If this is more of a slow upper GI bleed with a subacute presentation, maybe it's okay to just so again, here's the very general approach to major bleeding with a kind of a tiered approach of giving the reversal agent, trying to control the bleeding, stopping the drug and trying to control the bleeding, or maybe less of an intervention. So I'll finish there, and hopefully we have left some time for questions. Thank you so much for your attention.